Hi, and thanks for this kind introduction. I have nothing to disclose. Today, I'd like to discuss an important topic, the recent energy crisis in Europe and the need to save energy. The Paris Agreement of 2015 made it clear that we need to reduce carbon emissions in order to prevent dramatic climate change. An interesting fact is that 5.5% of the total carbon footprint is generated in the healthcare sector, where hospitals contribute about a third of this footprint. We find that radiology departments consume large amounts of energy. In fact, a single CT scanner in our department consumes as much energy as 5 four-person households, of which more than 2/3 is spent in idle state. However, we must ensure that patient care and safety is not affected. So we asked ourselves, can we reduce the amount of unproductive energy needed? We believe we can. The goal of this study is to identify energy-wasting devices in our radiology department by monitoring the network status of imaging modalities and PC workstations with live dashboards. How did we do this? Our tertiary care radiology department operates around 60 medical imaging systems, amongst them 5 CT scanners, 6 MRs, and 2 PET CT scanners. Additionally, we monitored 80 PACS workstations and 165 PCs. We were able to determine their online status using ping echo requests. A sample can be seen in the bottom left corner, and we tracked our devices in 15-minute intervals. This data was then presented on live dashboards that show the online status of each device. The Python script to do that is freely available on GitHub in case you're interested. We collected our data during 2 weeks in October and November 2022. We then announced this project amongst our staff and kindly asked them to turn off their devices during off hours. We continued the tracking and analyzed our data for changes in behavior. We were also able to identify constantly running modalities that could be turned off during off hours. What did we find? On this graph, the blue line represents the PACS workstations and PCs that were left on during off hours. As you can see, the number of these devices goes down from around 40 to a bit above 20, following our intervention. A similar graph is here for our modalities. As you can see, the number of modalities running during off hours went down from above 10 to around 4. On this slide, we can see a sample dashboard for 2 of our PET CT scanners. On the upper half of this dashboard, you can see the online status of our 2 PET CT scanners. At first, they were not turned off during the weekends. We quickly noticed this and started to turn them off during weekends. Right now, we are also starting to turn them off overnight. With this simple change, we were able to save more than 2,300 kilowatt hours of energy just in the last 4 months. This is equivalent to more than $500 of energy costs and more than 300 kilograms of CO2 emissions. And this was just one scanner. If we calculate the savings for all our devices, we find that in our department we can save more than 70,000 kilowatt hours of energy every year. This is equivalent to almost $20,000 of energy costs and more than 9 metric tons of CO2 emissions. Conclusions. In this project, we could show that idle devices present a significant opportunity to save on costs and energy. Just by reminding our staff to turn off their devices, we could show an effect on turn-off rates of our PCs. The estimated yearly savings of this intervention are as much as 14 four-person households. Of course, our approach also has several limitations. For example, devices with no network connection, such as most monitors, cannot be tracked. Also, printers they are usually in a low power standby mode where their network component is still on, so they can also not reliably tracked. In the future, we'd like to implement this method in other departments and hospitals and maybe even other industries, as we think there's a huge energy saving potential in this. Thank you very much for your attention.
So thank you, Manfred, for these presentations. Are there any questions from the audience? Yeah, please, can you please go to the microphone?
Okay, thank you. Very good presentation. And I have only one question. Do you use particular devices to calculate the energy consumed of every device? Or?
Yeah, we used a simple plug. You can connect it with your smartphone and then see the energy consumption of the device that is plugged in. And we use this, we average this data and use it as a baseline for our calculations. For large devices such as CT and MRs, we could pull this data from our hospital energy management system, which tracks the amount of energy consumed.
Thank you.
Yeah, there's another question.
Thank you for the idea. Very like it. I have a question regarding the PACS. You also turn off the PACS. How the radiologists like the idea that they don't have access 24/7?
It's not the PACS itself, not the servers, but the workstations where we see our pictures.
Okay, thank you.
Thank you very much. I'm pleased to present our research on MRI contrast agent reduction using CNNs. These are my disclosures. I'm funded by the University of Bonn, and I'm a co-founder of a medical software development company that also works on this topic, but without a direct relation to the work presented today. What we did is we implemented a unit-style network structure, which is the state-of-the-art for tasks like this, for dose reduction of gadolinium-based contrast agents in MRI using 10% of the standard dose. And we use different input protocols using only the T1 weighted images would be the standard setting. We used also to investigate not only whether the known benefit of prolonging the post-injection time remains, that the network was originally trained on shorter post-injection times. We used this 5-minute setting, which I come to later. And we also investigated the influence of other unenhanced sequences like T2 or diffusion-weighted sequences that are known to be important contributors in virtual contrast synthesization tasks. That was the MRI protocol. First, after application of 10% of the low dose and a waiting period of 2 minutes, a low dose image was acquired, and at the end, of course, full dose imaging was performed. In 30 patients, second low-dose image was acquired before the full-dose administration, with then already 5 minutes passed since the low-dose administration. So these 30 patients formed the test sets. Next to the quantitative analysis, a reader study was performed. For each synthesized sequence, the blinded reader scored the quality of the image and the interchangeable when it comes to the clinical conclusion compared to the two full dose, and for each lesion, the degree of contrast enhancement and the conformity of the lesion compared to the two full dose was scored. False positives were noted, and due to time constraints, I would like to move directly to those reading results. The evaluation of the overall quality of the image did not show any differences between the setting. So there's a particular danger in the fact that the general impression of quality is always very good, owing to the nearly perfect mimicry of the vascular signal, independent of its real clinical value, as you can see in the performance of the zero-dose setting when it comes to clinical interchangeability. But even in the standard setting, only 55% of the synthesized images were fully or mostly interchangeable. with the full dose without changing the clinical conclusion. Using low-dose images with a prolonged post-injection time, that would be the 5-minute post-injection time here, resulted only in a discrete increase of interchangeability. And interestingly, increasing the number of input sequences resulted in an increase in false positives and false positive contrast signals. So to our surprise, the addition of further input sequences worsened the interchangeability. And here are examples of false positive signals in the synthesized images of the extended and the zero-dose setting. And of particular interest are the associations of false positives with hypo-intensities of the T2 images, possibly because of the common association of the T2 vessel flow void and contrast signal the network had learned. Like here at the resection cavity, or down here at the cerebral aqueduct in the zero-dose setting, where the association with flow void becomes apparent again. All settings showed significantly poorer contrast enhancement compared with the original full dose, but otherwise we found no significant differences between the first 3 settings, and of course the zero-dose setting performed significantly worse. Here are a few example tumor cases. You can see here that although the mean score of contrast enhancement did not differ significantly between the acquisition time of 5 minutes, the post-injection time of 5 minutes, or the standard setting, extending the post-injection time sometimes resulted in a noticeable improvement in the strength of contrast signal, as seen in the top and third row, if you compare the standard to the 5-minute image. But as you can see in the second row, this behavior was not consistent. In some cases, an improvement in the appearance of the internal structure of the lesion was noticed in the extending setting, where obviously there was some kind of help from the high resolution of in-plane resolution of the T2 image. Last, I show you some cases where the relevant contrast signals are not represented in the synthesized images. For example, here the metastasis or resection cavity. These subtraction images show that the contrast signal simply did not exceed the noise level, so no reliable extrapolation was possible. The dose of 10% was simply too low. So in summary, only half of the images were interchangeable. The method was severely limited for smaller lesions like metastases or weak enhancement around resection margins, which became a major factor in our study because 70% of our cases were postoperative cases. And interestingly, the method was able to derive a benefit in some cases from prolonging the post-injection time, which is favorable for later application in the clinical setting, where the known benefit of increasing post-injection time should remain if AI is used. And the risk of using potentially misleading information from non-contrast sequences should be considered in future approaches. Thank you.
Thank you for your nice presentation. Are there any questions from the audience? Okay, no questions. Did you investigate the causes of this failure in the interchangeable, or?
I'm sorry, what?
I mean, did you investigate what could cause? I mean, could be the input sequence a cause of? You just investigated the T1 weighted, right?
Yes. The artificial dose created by the algorithm. Yeah, the main reason for the decrease in interchangeability were the increase of the false positives, because then often the clinical conclusion was not the same, especially in cases where the true full dose had no pathologic enhancement and the algorithm created one.
Yeah, my question was if the original sequence, the acquisition sequence, could be maybe adapted, or do you think that would impact on the results or not?
Yeah, the adaptation would be to increase the low dose. So that was the main thing about the false negatives then, that especially in cases like metastases and weak enhancement or resection margins, the noise level of the image, of the T1 image, is just higher than the low-dose signal, so you can't train against that.
Okay. Any idea to proceed further with this investigation?
The main idea were to higher the low dose.
Okay.
Yeah, thank you for the kind introduction, and special thanks to my previous speaker for introducing the topic of low dose. Let's now move this on to breast imaging. I got nothing to disclose, and actually this and the next talk by my co-worker Gustav are dealing with MRI-based breast cancer screening, which the USOBI recommends now for people with dense breasts. And as you all know, the breast MRI examination heavily relies on the DCE acquisition. So meaning the acquisition of images before and after injection of a gadolinium-based contrast agent. We believe that in the screening setting, a lower gadolinium dose is actually beneficial. So we asked ourselves if AI can help us to obtain high-dose images from low-dose images. And in this work, we employed diffusion probabilistic models, or DPMs in short, for this task. So DPMs are state-of-the-art image generators that you might know actually from DALI 2, actually a lot in the media right now, that generates images based on text input, and it uses diffusion models. These work by learning the chain of adding noise to a ground truth image in steps, and then they learn to revert this process of adding noise step by step. Yeah, and what does this actually have to do with our task? On the right you see two images. The upper one is a high-dose images that is characterized by a high contrast to noise ratio, so because there's a lot of contrast agent in the lesion, and in the bottom, a low-dose image would be then characterized by less gadolinium in the lesion, hence less signal, meaning the signal gets reduced, but the noise level stays the same. So we get actually to a noisy version of the image, and the task that we want to accomplish essentially comes back to denoising the low-dose images. And what you could imagine from this chain is that diffusion probabilistic models are perfectly suited for this because they have learned to go this backwards process. So we set up a DPM and trained it on about 10,000 breast MRI examinations from our institution. And what we then did is to take 50 test images of enhancing lesions, to which we added increasing amounts of white Gaussian noise to mimic low-dose images. And yeah, then I'm first going to show you some image example. So you will see now a video. On the left, the noisy input images to test the model. In the middle, you're going to see the recovered images, and at the right, the original to compare. So I'm starting now, and you will see how the amount of noise progressively increases on the input, and then the recovered images. And in general, we found that the recovered subtraction images stay remarkably close to the originals, even for the very high noise levels. To get this a bit more quantitative, we also calculated the structured similarity index that, according to our expectation, decreases with increasing noise input between the recovered images and the original. And then we also did some visual evaluations, and actually the gross location of enhancement stayed correct for over the whole noise range for 37 out of the 50 test cases, and remained correct until quite high noise levels of 0.24 for the remaining lesions. Lesion structure details and background structure details started to get lost from noise levels of 0.1, like the very first subtle changes occurring, and this would correspond, roughly estimated, to half of the gadolinium dose. So in conclusion, DPM can recover full dose information from virtual low dose low-dose images that have a variable amount of input noise. In the sense, they are a little more flexible than training a generative adversarial network with a fixed noise level only. And we hope that DPM could enable screening with less gadolinium in the future. But of course, future work remains to be done, especially to acquire real low-dose images to test the model, and also maybe to improve stability towards higher noise levels. And with this, I thank you for your attention, and I would like to acknowledge support of an ESR seed grant. Thanks.
Thank you for the presentations. Are there any questions from the audience? No, I might have one myself. So do you want to acquire real images to get a clinical test? I mean, to be reviewed by radiologists, because maybe this is the next step, or?
Yeah, actually, we hypothesize that the virtual noise images are true representations of what we would get by injecting less of the dose, but to make this comparison more valid, I think, clinical low-dose images would be way better.
Okay, there's a question from the audience.
Yeah, I saw that you did like visual similarity, but did you also have like a diagnosis for all these cases and did a diagnostic assessment?
Actually, this remains still to be done, so yeah. Thanks for the question, very valid point.
Yeah, hello everyone. Thank you for the nice introduction. As we heard from Dr. Nolte, diffusion models might be a promising way to reduce the need of contrast agents in breast MRI. And besides these diffusion models, there are also so-called generative adversarial networks, and they are more established in research. Therefore, I would like to give you a presentation how these models can be used to reduce the need of contrast agents in breast MRI and demonstrate it in a more clinical setting. Before I start, I have no conflicts of interest to disclose. Breast cancer is one of the most common types of cancer in women and a major cause of cancer-related deaths. Therefore, screening plays an important role in early detection and eventually survival. As we just heard from the previous presentation, for women with dense breast, new guidelines recommend contrast-enhanced MRI screening. However, the use of contrast agents can be problematic. Therefore, we simulated the injection of only 25% of the normal dose and investigated if a generative model can be used to recover the contrast-enhanced image from this virtual low-dose image. For this purpose, we used the MRI examination data from our institute, which has been collected since 2010. The data were then split into two groups. The first group, which included a little less than 10,000 MRI examinations, was used to train the model, and the second group consisted of 200 MRIs and was used for testing purposes. For the training of the model, we took the subtraction image and simulated a low-dose image. The generative model received this low-dose image together with the T1 and T2 weighted images as input. And based on this input, the model predicted a post-contrast image, which was then compared with the real post-contrast image, so that the model could learn to improve its predictions. In a first experiment, we showed two radiologists the pre-contrast images and either a real or synthetic image. The radiologist then had to say whether they saw a real or synthetic image. Based on the confusion matrix, which you see here on the right side, you can see that the radiologist classified most of the synthetic images as real, which overall resulted in a low accuracy of about 50%. So it was almost impossible for the two radiologists to distinguish real from generated images. In a second experiment, we showed the radiologist real and generated post-contrast images of lesions. And the radiologist then rated the conspicuity of the lesions on the synthetic image. So we used a scale of 1, which meant poor, to 5, which meant perfect, and we rated this in comparison to the real images. And as you see here on the right side, the radiologist reported that all lesions in the synthetic images had a high or even perfect conspicuity compared with the real images. Here are two examples from the data set showing the pre- and post-contrast images and the virtual low-dose image. And patient A has a mass enhancement so that the lesion is already clearly visible in the pre-contrast image, while patient B has a lesion that is not directly visible in the pre-contrast image. If you look now at the reconstructed post-contrast image, you will find hardly any differences to the real post-contrast image, and the lesions are clearly visible for both patients. And we were encouraged by these good results, and we asked ourselves if it might be possible to reconstruct the post-contrast image solely from the pre-contrast images. Therefore, we tried a second approach in which we only used the pre-contrast images. And as you can see here, this made little differences in the first case, but in the second case, the lesion disappeared completely. So based on these results, I would like to draw the following conclusions. The first among them is that generative models possess the ability to create highly realistic looking post-contrast images. However, despite their impressive performance, GANs are not really reliable when it comes to predicting the enhancement of lesions solely from the pre-contrast images. On a positive note, the study showed that generative models can reliably recover the enhancement from a virtual low-dose image, and this might be a promising first step in the development of methods to reduce the dose required for screening. Thank you very much for your attention.
Thank you for the presentations. Any questions from the audience? I have one.
Sure.
Of course. You said GANs cannot really synthesize lesions from pre-contrast images, but how low can be the low dose?
Oh yeah, that's a good question. So we tried to figure out how low we can get, and it turned out like 25% is a good rate. So we asked the radiologists, and that was the minimum where they could see the lesions. When we said there should be a lesion, and then they said yes, we can still see it. But I think that's also very interesting in comparison to Dr. Nolte's talk, because there we are more flexible in the rate. So this time we need to retrain the model each time we want to see if a different dose would work. But with her approach, it would work also with like 20% or 10%, and we are more flexible then.
Nice. Thank you.
Oh, thank you for the introduction. I'm Quint van Lohuizen. I'm part of University Medical Center in Groningen, where we try to accelerate the acquisition of MRI scans. We do this in a collaboration between 3 different institutes in the Netherlands. So these are my disclosures. So within the topic of fast MRI, we try to accelerate MRI scans for diagnosis. But we suffer from an effect called the hallucination effect. And we can see an example of this in the fast MRI challenge in 2020, where you see a ground truth, which is fully sampled MRI scan from the clinic, and a deep learning reconstructed MRI scan. And what you can see here indicated with the red arrow is that there is an unfaithful reconstruction of the underlying anatomy, even though that the accuracy is very high, the reconstruction accuracy. So what we see in the literature, there is a lack of systematic diagnostic evaluation of AI reconstructed MRI on a large cohort. So therefore, I would like to propose the research question: does AI reconstruction on MRI restore diagnostic accuracy? So we do this in a prostate cancer reconstruction and detection setting, where we evaluate AI reconstructed MRI with the detection AI on a large cohort. So our data set is a multi-center data set with 3 different institutions from the Netherlands. We have T2 weighted axial view prostate scans with and without clinically significant prostate cancer, where we define clinically significant as being pirates bigger or equal to 4. We have expert delineations by abdomen radiologists. So our diagnostic assessment framework works as follows. We start off with our T2-weighted axial view prostate scan, which we call the original or R1 scan, acceleration 1, it's unaccelerated. We undersample this in case space, retrospectively, and we call this the naive or IFFT reconstruction, which is the inverse fast Fourier transform, but just let's call it naive or IFFT. And what we do is we give this to a reconstruction AI, a UNet, and we call this the UNet reconstruction. It brings back details and de-aliases the images. This UNet reconstruction we give to a detection AI that tries to detect the presence of clinically significant prostate cancer. So each voxel gets the likelihood of clinically significant prostate cancer. And we compare this with the ground truth. So if we go to the results and assess these reconstructions based on visual quality in terms of structural similarity index measure that measures how similar are two given images, 0 being very dissimilar and 1 being perfectly similar, then we see that AI reconstruction creates prettier images because, as you can see here, that the purple, the R4 UNet, the deep learning reconstruction, has a higher SSIM score than the naive reconstruction or the IFFT reconstruction. So visual quality increased with deep learning. But what about a lesion level assessment? We do this in terms of the Frock curve, where we measure the area under the curve here. So if you look at the original detection AI on the fully sampled images, the green curve, we see that it performs the best. Detection on original images is better than on the reconstructed images because the partial area under the curve is higher. And interesting here is the two curves below that, is the detection performance between the R4, the naive reconstruction, and the R4 UNet reconstruction is similar. So diagnostic performance was not recovered, only visual quality was recovered. Here we see a good example, a good hallucination example. In the top row we see a fully sampled MRI scan of a prostate, and on the left side you see a nice continuity of the peripheral zone. And the detection AI did not detect any clinically significant lesion in here, which is correct in this case. And on the bottom, we see a UNet reconstructed, fourfold accelerated, reconstructed prostate scan. And we see that there is a discontinuity of this peripheral zone, which the detection AI signifies as a false positive. It found a significant lesion over here, which is actually not the case. So it is an unfaithful reconstruction. So the key insights here are deep learning reconstruction recovers visual quality, but diagnostic accuracy actually reduces. And be aware, pathological features may be ignored or even distorted. Are there any questions?
He's doing my job. Thank you. Are there any questions from the audience? Yeah, I'm quite impressed by the fact that because most of these applications are driven by visual evaluation of the images. Is there any quantitative way to evaluate the image so you can get rid of this visual bias or not?
In the literature, you see that everything is compared with structural similarity index measure, for example, or other visual quality metrics, but then they do a diagnostic assessment on just a very small cohort. But what you want is that you take an MRI scan for a reason, for a diagnosis. So this should be taken into account, like a segmentation or some kind of degradation of some disease or regression problem. This should be taken into the reconstruction itself, so that you reconstruct for diagnosis and not for
visualization.
Yeah.
Okay, thank you.
Good afternoon, everyone. So straight away coming to the rationale of this study. So we know signals from the PET images, they consist of the true coincidences, and these are used for the image formation. Whereas the scatter and the randoms, they contribute to the image noise and they degrade the image quality. Also, to improve the image quality, higher dose of radiopharmaceuticals is recommended for the conventional scanners. These are the analog scanners. The new digital PET-CT systems, which have the silicon photomultiplier tube, they offer better sensitivity and enable to reduce the administered dose. Also, new AI-based denoising algorithm they identify and remove the noise signals to improve the image quality. Now, aim of this study was to investigate the effect of deep learning-based denoising method on image quality and semi-quantitative parameters of low-dose FDG PET scans acquired with digital PET-CT. Also, to investigate whether deep learning-based denoising methods, they can help achieve optimum image quality with reduced acquisition time and reduced dose of FDG. Now, how we went about this study? We recruited around 55 oncological patients who were scheduled for FDG PET-CT scans in our hospital. These patients were fasting for around 4 to 6 hours, and we injected 2.6 megabecquerel per kg body weight of FDG. This is the half the recommended dose with the normal analog scanners. And the uptake period was kept to around 60 minutes. And these patients were imaged with digital PET-CT scanners in which vertex to mid-thigh CT scans were acquired, followed by PET acquisition. For PET acquisition, list mode acquisition of 1/22 or 2 minutes per bed position was done. Now, this data was rebinned into 5 data set. For the 1/22 image, having 100% of the counts served as a reference image. The 90-second, 60-second, 45 seconds, and 30 seconds images, they had 75, 50%, and up to 25% of the total counts respectively. Now, all these images were reconstructed by OSEM algorithm. These reconstructed images were now post-processed with either deep learning algorithm, that was hyper DLR, or we are calling it HDR, and Gaussian filter, or non-HDR images to produce 10 data sets for each patient. Now, how did we analyze the data? First of all, we had to ascertain whether the low count images are missing out any lesions. So for this, we took around 110 FDG avid lesions with diameter of more than 1 centimeter on the CT images. Lesions were called detectable if focal uptake of SUV max at least 2 times more than the immediate background was noted. Also, we did analysis. We did semi-quantitative analysis of SUV max, SUV mean, signal to noise ratio in liver and mediastinal blood pool by having a standard ROI of 3 centimeter over right lobe of liver, avoiding any blood vessels, and 2 centimeter ROI over mediastinal blood pool, avoiding the myocardium and the blood vessel wall. Also, background noise and lesion contrast, they were evaluated on a 5-point Likert scale. Now, these are the images of a single patient, and these are the different data sets with NHDR being the Gaussian filter and HDR being the denoising algorithm which was applied. We can see the 120, these are the 1/22 images with the denoising algorithm. And these are the 1/22 images without the denoising algorithm. This is the Likert scale which we used. The score of 1 was given if there was a high background noise and the worst contrast, and score of 5 was given if there was very little background noise and the lesion had the high contrast. Now, coming to the results, we had 55 patients, 33 males and 22 females. As told earlier, the average injected FDG dose was half of the recommended what we use for the conventional scanners, and average uptake time was 65 plus minus 20 minutes. Now, coming to lesion detectability, this was the most important aspects. So all the lesions which we studied with diameter of more than 1 centimeter, they were adequately detected in both HDR and non-HDR subsets. Coming to image quality and noise, image noise was significantly less. In the HDR group, we can see the high median HDR scores compared to the non-HDR images. However, the significant difference in lesion contrast was observed only in 30-second and 45-second data sets. Now, among the HDR group, background noise and lesion contrast showed no significant difference between 1/22 and 90-second images. However, there was a significant difference among 120-second, 60-second, and 45-second images in the SGR group. Now, these are the transaxial slices of PET images of a patient with oral cancer, and these are the fused FDG PET and CT images. This is the non-SGR group, and this is the SGR group. We can see with the increase in acquisition time, there is decrease in the background noise. Also, for each subset, the denoising algorithm plays a very good role, does a very good job in reducing the background noise. Coming to the semi-quantitative parameter, SUV max in liver and mediastinal blood pool, they were significantly different for all the data sets for SDR and non-SDR groups, whereas there was no significant difference in the SUV mean values. For SNR, that is signal to noise ratio, there was SNR values were significantly different for between SDR and non-SDR groups, and the SNR was quite higher, at least twice that of we noted in the non-SDR group. Now again, these are the transaxial slices of fused PET-CT images with liver in the picture. We can see, again, with the increasing acquisition time, the noise is very significantly reducing in both the groups. Also, the denoising algorithm does a very good job in reducing the noise. Similarly, in the mediastinal blood pool. Now, we did a intra-group comparison between 120-second reference and 90-second images in the HDR group. There was no significant difference in SUV mean, max, and SNR in liver and mediastinal blood pool in these images. However, while comparing the images of HDR group of 60-second and 90-second, there was a significant difference observed in the signal to noise ratio in the liver. Overall, if we see, there is no significant difference between the 120-second image and 90-second image, and to quite a good extent, the 60-second images were also similar to the 120-second image. So to conclude, deep learning-based denoising method results in significant reduction in image noise and increased signal-to-noise ratio compared to Gaussian method in low-dose FDG PET scans. Image acquisition time per bed position can be reduced to 90 seconds, potentially to 60 seconds, without compromising on the image quality and semi-quantitative data. Also, digital PET-CT systems, they have potential to cut down the scan duration and radiation dose to the patient by half, compared to the current clinical practice. Thank you.
Thank you for the presentations. Are there any questions from the audience? I had one, but you anticipated it in the conclusions. I wanted to ask if it could be used instead of reducing time to reduce the activity injected to the patient. So that's.
So basically, in our practice, whenever even we have done the full-time acquisition of patient with 2 millicurie dose, that is almost 1/3 or 1/4 the conventional dose which we give to the patient. So we can very much do that. Yeah.
And also for very large patients, did you investigate different kind of patients? Because you only had 50 patients.
Yeah,
so
patient number is quite less. So that is the next step which we'll be doing, comparing on BMI and lesions less than 1 centimeter. We need to look at that.
Okay, thank you. Thank you.
Thank you for the introduction and for the opportunity to present our work here. It's a bit different topic. We're talking now about CT and pulmonary embolism and repeat rates. And I have to disclose that this work was done under a research agreement with Qualem. So, next one, yeah. So a little bit of background. A pulmonary embolism is a blood clot that obstructs a pulmonary vessel in the lungs. And when this is the case, it can have morbidity or mortality even. So it's really important to diagnose this pulmonary embolism on time. And the main modality to do so is a CT, so a CT study. And this consists of a localizer, a test bolus, and a thorax pulmonary embolism scan. The reason for this is that it's very important to have contrast between the blood and the blood clot. And to do so, a contrast agent is injected. And the timing of this contrast agent with the actual scan is very important. If it's too early, you have no enhancement, and too late as well, so you have to be on time. And that's also the reason why it's sometimes quite tricky to have the scan right and why the scans are repeated. Now, a repeated scan, it's CT, so it's X-ray radiation, so it means an increased dose, radiation dose, but also an increased contrast dose, which has some risks. And as well, it reduces a bit the department efficiency because you have to take some time to decide whether you need to do a repeat or not. So that's why we looked into these repeats. We want to see what is the repeat rate of these pulmonary embolism scans. And we did this in two ways. We had a manual analysis and an automatic analysis, and we wanted to compare them because in the end, an automatic analysis is more time efficient than doing it manually. So what we did is we collected 5 years of pulmonary embolism scans in the 5-year period, and we extracted DICOM metadata from our dose monitoring system, the list that you see on the bottom. And with this information, we could calculate then these repeats. The manual analysis, we looked at the series descriptions of this pulmonary embolism scan, and we coded them, whether it was a pulmonary embolism or other. And then in the next step, we used an Excel script to basically count per examination how many of these pulmonary embolism scans are there. And if there are more than one, then it's a repeat. And in the final step, we visually inspected all these repeats to see whether there are true repeats or, yeah, we had to exclude them. In the automatic analysis, the same data set was fed to the algorithm, and the algorithm first looked for base patterns. So you have this, in principle, these 3 series in the examination, and it looked, what are the base patterns that can be found. And here there are 2 as an example. In total, there were 6 found. And these 2, you see that they are the 3 series, and there's also a base pattern with 2 localizers. Well, in the next step, the algorithm looked at each individual study and looked, okay, what series are in there and compared these with the base patterns. And in this case, you see that there's an extra thorax pulmonary embolism scan, so this is then a repeat. Coming to the results, so we had nearly 5,000 pulmonary embolism studies, of which we saw 150 repeats. These were all inspected, and then we excluded 16 of them, and we ended up with 134 repeats, which means a repeat rate of 3%. And yeah, I don't have time to go into this, but my colleague Babs Hendricks has a poster going in further detail about the reasons for repeats. So if you like, please go to her poster. This is a screenshot of the dashboard of the automatic analysis. So there's a lot of information there. Well, I also don't have time to go into that much deeper, but if you go to the Qualem booth, they can explain all about it to you. For me, now I focus on the repeat rates. So the automatic software found 229 repeats. But looking at them, we saw that there were lots of repeats that consist of abdomen repeats in different phases or thorax repeats in different phases. So not pulmonary embolism scans. So these scans were not within the scope of our study, so we excluded them. And then we end up with 139, and looking at them visually, at the same visual scoring as we did before, there were 10 of those that also were excluded, ending up with 129, which means a repeat rate of 2.9%. So this brings me to my conclusion. We found a manual repeat rate of 3.0%, automatic 2.9%, so this is a good agreement. And so we think this repeat analysis is a very valuable tool for quality control. You can, with this automated software, you can do some continuous monitoring, see if your repeat rate goes up or down. But you can also look at these flagged repeat studies to see what are the reasons for that and can you improve then your practice. And with this, I would like to conclude and thank you for your attention.
Thank you for the presentation. Any questions from the audience? Do you plan to extend your evaluation to other protocols than pulmonary embolism, other evaluations? Yeah, the idea is to, because now we focus on this pulmonary embolism, but in principle you can put in all your CT scans that you have, and the algorithm, because it's automatic, it looks for this base pattern, so it can be on abdominal scans or
PET scan. So that doesn't actually matter what the indication is.
And just CT or other modalities as well? Like,
For us, we will focus on CT for now, yeah.
yeah, because there's a lot going on for radiologic, conventional radiography, also projection rate evaluation. So.
Yeah, first of all, you have the same motivation because you have also this radiation exposure and also efficiency that you want to gain. Yeah.
Yeah.
So,
thank you.
okay.
Thank you.
Thank you.
If there
Thank you for the kind introduction and welcome to my presentation about deep learning-based image denoising in imaging of urolithiasis. Those are my disclosures. So why is urolithiasis an important topic? The lifetime incidence in developed countries is pretty high with around 15%, and the risk of recurrence is even higher with about 50%. And treatment decision depends on clinical setting. And the main recommendation of the European Society of Urology is a non-contrast ultra-low-dose CT of the abdomen. As for CT imaging, those are the established reconstruction techniques, which I think most of you are familiar with. It all started with filter back projection in the 70s, and over the past decade, hybrid iterative reconstruction and model-based iterative reconstruction successfully replaced it, with allowing improved image quality at reduced radiation doses. But there's another more recent approach, and that is deep learning-based reconstruction. It already showed some promising results in different areas of use, but still information about efficacy is sparse. Mostly it needs raw CT data for reconstruction, but the algorithm we investigated only needs filter back projection image data, which makes it potentially more vendor independent and also more sustainable because there are less requirements for computational power. What we did is we included 76 patients with suspected urolithiasis. They all received an unenhanced low-dose CT of the abdomen and at the CTDI of 2 milligray on a standard Philips ICT in supine position. FBP, HRR, and MBR were reconstructed at a slight thickness of 2 millimeters with a section increment of 1 millimeter, and though the FBP image data was post-processed using Pixel Shine, a deep learning image denoising algorithm. To give you a feeling about image impression, there's actually a concrement in the left ureteral ostium, which you cannot clearly see, I think, in the FBP image because there's a lot of noise, and we can all agree that the noise significantly decreases in DLID and HIR. And then at the bottom right, we have model-based iterative reconstruction with its classic smooth texture, and we probably all agree with the least image noise in all four images. We placed ROIs in different tissues, then calculated signal in contrast to noise ratios, and had 2 experienced radiologists evaluate image quality and diagnostic quality or accuracy on 5-point Likert scales. And then we evaluated the detection rate of kidney stones in a task-based IQ assessment and performed multiple statistical analyses. So as you can see for the results, the attenuation was pretty similar over all the reconstructions with only slight advantages for model-based iterative reconstruction, whereas the noise significantly decreased from FPP to HIR to DLID with best or lowest values in MBIR. Naturally, this results in higher signal and contrast to noise ratio in MBIR as well as DLID, both being significantly higher or superior to filtered back projection in HIR. Here's a visualization of the image quality as rated by our radiologist. It shows that MBIR got the best results, followed by HIR and DLID, both having a 3 out of 5 score in all categories in the Likert scales, and FPP is inferior to all the other reconstruction algorithms in image quality as well as image noise. Here's another example, this time of concrement in the left renal calyx. And as you can see again, the delineation of the stone is already better in DLID and HIR as in filter back projection, which is important for the size measurement, and is probably best in the bottom left image again, which is model-based iterative reconstruction. I think this image impression also shows in the results of diagnostic accuracy of the 104 urinary stones present in total in all those 76 CT scans. MBIR managed to detect 0.94 in total of them, followed by HIR and DLID, again scoring similar results with 0.9 in diagnostic accuracy, and filter back projection again being inferior with 0.84. Limitations of the study are it was only monocentric, we only had data from a single CT scanner, and MBIR was the reference standard because of best image quality. In conclusion, DLID increases objective and subjective image quality compared to FPP and HIR, and also diagnostic accuracy is comparable to HIR and superior to FPP, but DLID has a large potential for widespread clinical use since it doesn't need raw CT data and is not bound to a single vendor or scanner, and computation power is less demanding. But in the end, MBIR remains state of the art. Thank you.
Thank you for the presentation. Any questions from the audience? Okay, do you think about expanding your evaluation to other scanners and other centers, or you just conclude saying MBIR is better and so we don't proceed further?
We've been actually in talks with the vendor of this software, and there are a lot of parameters you can actually change and apply to the user's preferences. There's no actual project planned right now, but there are a lot of things still to be discovered in this topic, I think, and there will probably be more studies, and it will be interesting to further explore in different areas, of course.
Yeah, I think so.